So now we're going to hear from another staff member from the early years of the scanner. Dr. Patrick Sheedy III earned his undergraduate degree at the University of Notre Dame and attended medical school at the University of Pennsylvania, followed by an internship at Henry Ford Hospital. He came to the Mayo Clinic Radiology Department in Rochester for a fellowship in 1965 and was asked to join the staff full-time in 1968. After a 2-year stint in the Air Force, he returned to the radiology department in 1970, where he worked through 2014. His special interests were angiography and computed body tomography, and he feels both lucky and grateful for his career and experiences. And Dr. Sheedy is the reason I'm in CT. When I arrived, he had a need in Imatron, and I sort of became his physicist. So I learned CT on an Imatron under his guidance. Patrick?
And Cynthia, did you ever help us so much when you first came here, and on and on? And I really appreciate your putting on this symposium commemorating the 50 years that we've had with CT scanning. Glenn, I appreciated that, your presentation, and I hope you recognize that this is a grandfather talk. Because we're the only ones that remember that kind of thing. And it's also interesting, both from Notre Dame. Go Irish. And where's Daryl Holtz? Daryl was very important in the early days of CT. And the picture where you were was with Baker, Daryl Holtz doing the scan, and a guy named David King, who was an EMI person who was here quite a bit with both the head scanner and the body scanner. As background, I think Cynthia mentioned, I came here in 1965 with David Stevens, who I suspect is watching on Zoom. I wish he had been here because he helped me with some information for this presentation. There were 5 or 6 others who came here in 1965. And at that time, the state of radiology was way different than it is now. The backbones of radiology were chest x-ray, oral cholecystogram, excretory urogram, upper GI, and colon examinations. They were the routine radiology procedures. And I suspect that more than half of the people who came here got all 6 of those examinations as a part of their checkup. It was also the red goggle era. I suspect many of you are physicists here, maybe don't remember the red goggle era, but for the first 6 months we were here, we had to do dark adaptation with red goggles before doing fluoroscopy because there was no image intensification of the fluoroscopy. As Glenn mentioned, after the success of the head scanners, there's quite a bit of excitement about the potential for a body scanner, which didn't come for another 2 years. But before that, Glenn Hartman, who was the chairman, had appointed Dr. Sheedy, Dr. Stevens, and Dr. Hattery to be the head persons for the coming of the body scanner. And right away, they tried to do some body scanning in the head scanner. Dr. Stevens euthanized the guinea pig, froze it in the trunk of his car in the winter, and then tried to use a bandsaw to slice it up so we could compare the images to the CT images that were obtained in the head scanner. Unfortunately, the bandsaw heated up the guinea pig and it was no good. Dr. Hattery put many kidneys in the head scanner, I remember. Recognizing we could, oh yeah, you could really tell a cyst from a tumor, or you could see tumors. And the report that at one of the sites that had the head scanner, they got a real skinny guy slit him that was able to fit into the aperture for the head scanner, and they got some body scan images. Our first EMI scanner came in 1975, and it was called 5005 Emerald. The English liked nicknames for things, so it was called Emerald. It was a 20-second scan. The importance of that being, one scan could be obtained in a breath hold, so the patient could hold their breath. The scan was 13 millimeters thick, and the ordinary abdomen exam would be about 8 images, and it took about an hour. Pictures were displayed on the cathode ray tube and were captured with Polaroid film, as you saw on the image. Darryl, how many Polaroids do you think you ever took? Thousands, I'll bet.
Polaroid in business.
Yeah, and the other thing is that enhanced that business was we made 2 copies all the time, so that we could dispatch one Polaroid copy to the clinician who referred the patient, and we kept another in our department as a so-called teaching file, so that if I was there for a week, Dr. Hattie would come around, Dr. Stevens would come around, and we would be able to compare notes and look at the images together. Dr. Stevens just recently told me that the first body scan that he remembers was in October. And he recruited a patient from the GI section who had known carcinoma of the pancreas, and scanned him because the pancreas was an elusive organ. And unfortunately, the scan wasn't very good because the patient was so emaciated. There was no fat surrounding the pancreas or the other organs in the abdomen. But also on that same scan, there was a reporter by the name of Jane Brody from New York Times wanting to see this first body scan. And she was annoyed, pissed off really, that she couldn't be in the scan room when the scan was being conducted. And the scan got done. I think Darryl probably did the scan. And Dr. Stevens came out of the room and said to Jane Brody, "It works." And the New York Times the next day had an article by her, and it said, "It works." I very specifically remember many early cases we had. They were so impressive. There's a man named George N. He had a scan. We thought it was carcinoma of the pancreas, a great big mass. He came back a year later and was still alive, which would be unusual for cancer of the pancreas. And as it turned out, he had an islet cell tumor of the pancreas, a neuroendocrine tumor. Wasn't adenocarcinoma of the pancreas. Another man by the name of Jack V. He had a large defect on a radionuclide scan, and we did the CT scan on him, and it wasn't a liver tumor as had been thought. It was rather an adrenal tumor that was eroding into the posterior aspect of the liver. Another patient that I called the pheochromocytoma patient had symptoms, laboratory tests for pheochromocytoma. We scanned them and found a mass in the retroperitoneum. And we told the surgeon, there's a mass in the retroperitoneum. The surgeon operated on the patient, came back and said, "We didn't find any." And I said, "Well, did you get behind the left renal vein into the retroperitoneum?" And he said, "Yeah, well, I palpated there." And I said, "Well, let's scan the patient again." We scanned him again, and there it was, still there, about as big as an orange. And I said, "Well, it can't not be there, because there it is again." Reoperated on the patient, and he had a retroperitoneal pheochromocytoma. The surgeons in general were a little slow to be accepting, because one of the big deals in general surgery was exploratory laparotomy. But I would say probably within a year, that notion of exploratory laparotomy went away. And that was no longer a diagnostic test. And if you would wander the operating room areas, very soon after the body scanner came, there would be always pictures on the wall. First Polaroid pictures and later X-ray film type pictures, because the surgeons now had a target to go after based upon what had been seen on the CT scan. Also, initially the thought was, oh, this is going to be a good tool for the abdomen, but it became very clear quickly that there were very significant potential applications in the chest and in the musculoskeletal system. And quickly, other of our staff were added to our rotation, particularly when we got the second and third scanner. We had very good communications with the other universities that had CT scanners, body scanners, Mallinckrodt Institute of Radiology, Cleveland Clinic, and others. And we were always on the phone back and forth with each other. And I remember speaking specifically with Bob Stanley from Mallinckrodt about an issue. And we were discussing, do you think we really are able to see the normal adrenal glands? I mean, it was such a surprise. The interpretations of the initial scans were challenging and difficult because there was nothing in the literature. There were no articles written, no books, no book chapters, and even there were no cross-sectional imaging depictions. There was one atlas, I think it was called Eckelsheimer. David Stevens could remind me of the correct pronunciation, because the Eckelsheimer's had chest and abdomen cross sections, but the images were backwards from what we were looking at. And I remember so clearly David Stevens holding a mirror up to this open. Sorry. Holding the mirror up to the atlas, trying to get right, left, and up, down orientation so that we could compare what was in the atlas with what was on the cathode ray tube. So overall, I would say that the movement into body scanning was a totally empirical experience. And conclusions were based on observations and follow-up of cases, which we all found to be very important. Many of us would go into the operating room to compare what we saw on the pictures to what was actually found at the time of the operation. Glenn had mentioned that there was communication with, and I had mentioned, with other places that had body scanners. Cleveland Clinic had Alfidi and Haga. Mallinckrodt Institute of Radiology had Stanley and Sagel, and we were talking to them all the time. And as their experience was, so was ours. And Glenn mentioned this as well. We had many visitors. And I would say the scan rooms would be crowded each day with visitors. And it was interesting to me that the first wave of visitors were usually the young doctors who were paying attention to new things. Then the second wave would be the older doctors in their practices who were wanting to see if these young guys were making sense. And then the third wave would be the administrators of the practices who wanted to see and wondered how much it was going to cost them. I think that also Glenn mentioned this, there were many political issues at the time, certificates of need, both local and national. I had a handwritten note, and I couldn't find it, from President Jimmy Carter, who said, we need to be cautious about this. There could be too many. and they would be too expensive. I remember, and it was probably early on, somebody making an estimate that we probably needed body scanners, but probably only 3 or 4 of them in the USA. Isn't that amazing? Eventually, we kept dealing with all those visitors. And I would say within a year, Mallinckrodt Cleveland Clinic, we decided to form a Society of Computed Body Tomography, and put on a postgraduate education course to deal with the high level of interest, and maybe to tone down the large numbers of visitors that were coming here all the time. There were a lot of reactions to the results with the body scanner. I remember an article in the New England Journal of Medicine that was entitled "Cat Fever." I remember my colleagues here and at the other places that had a body scanner will say, "That's really dumb. It's intuitively obvious that this is a new breakthrough." And David Stevens, I attribute this to him. I hope he's listening. I remember him referring to the body scan results as the physical exam of the 70s. And it goes on in a way. So is it. It still is that. It still is that. As it continued, there were other controversies. I remember being at a meeting at Harvard with Juan Taveras, who had put on the meeting. He was a neuroradiologist. And there was a controversy of how we should look at these images, because the neuroradiologist looked at the images from the top down, which was the view that the neurosurgeon would have when he went into the brain. However, in the body area, most surgical procedures were done with a surgeon at the side of the table looking bottom up. So we had a big argument about how to resolve that. And the body scan group finally prevailed. And now, at that time, and now, the images are viewed from the bottom up. And as Glenn also had mentioned, there were, as it went on, more people got involved, and the discussion came up, is this a modality? Is CT a standalone thing and everybody should do it? Is it general radiology? Or should it be organ oriented? Should it be GI, GU? And that's the way it ended up turning out. And then there were introduction of many new applications that are still occurring now. I remember specifically the early biopsies, the early drain procedure, the use of CT for cardiac, use of CT for diagnosing pulmonary embolism, and on and on. That list grows. So how was it to be involved, which we were? I personally feel very lucky and grateful to have been involved in such an area that produced such information on an empirical basis. I don't think anybody seemed to be overwhelmed by recognizing new things, because it was relatively easy to add new things. But sometimes, and for some people, it was difficult to let go of things maybe you were good at. Specifically for somebody like me, I no longer ever had to do an adrenal angiogram or a kidney angiogram, because the answers were already there. For the young radiologists, and probably not too many here because they're all working, I always indicated to them that to remember that you're basically a sick person's doctor. You're not a totally tech oriented. And if I had a chance to tell the young doctors, I'd say, here's one way to improve the acceptance. Is to, after you view the scan, call the referring doctor that sent the patients to you. Compliment them if what you found was what they expected. Tell them, guess what we found on your patient? So that you got a good connection with the referring physician. That's about the end of my stuff. And I do want to hark back to Daryl Holtz, very important in our practice, and to David Stevens for bringing up physical exam of the 70s. Interestingly, I go about every 2 to 3 years and get my total body scan. Thank you very much, Cynthia. We really appreciate you putting on this symposium. I appreciate the help you gave me from that.